Welcome to the Adoption and Benefits of Digital Pathology for Primary Diagnosis, sponsored by Sectra. I'm Mary Tierney, the Chief Content Officer of TriMed Media Group. Salford Royal Hospital NHS Foundation Trust, a 728-bed hospital in Salford, United Kingdom, is a hospital with a mission to bring on board digital pathology. Their path began in September 2014 when they launched a pilot study within their neuropathology section with the help of Dr. Daniel Duplessis, who specializes in neuropathology and leads the institution's Department of Cellular Pathology, as well as a colleague. The 6-month pilot of the Sectra Digital Pathology System led to a second and broader pilot that is now progressing within the breast and gastrointestinal pathology sections of the hospital. The goal is full deployment across the facility and network of 3 hospitals in the northwest of England. Dr. Duplessis will talk about speeding up diagnosis and workflow, the advantages in multidisciplinary team meetings and examining priors, boosting quality and reporting, and the ergonomic and cost advantages. He was a quick convert to digital pathology, using terms like very easy to navigate and feeling more in command with the digital pathology system. He also offered advice to facilities looking to bring on digital pathology. At the conclusion of the webinar, he will answer your questions. You can submit a question by typing it into the Ask a Question box and hitting Submit. Let's listen in.
First approaches were made beginning of 2013, and then eventually after some negotiation we decided to start the pilot study in September of last year. A joint effort, so the UK government was involved, the Department of Trade and Industry, so there was some representation there, and then Sectra, who have an established track record in PACS systems for radiology, but who were developing similar system for tissue pathology or histopathology. And then we decided in-house within the Department of Pathology to specifically use the neuropathology unit to pilot it, because it's sort of a small super specialized group, 2 consultants with a very defined, much smaller section of the work, much more the volume of cases coming through each day would have permitted using scanning technology that weren't required to use a massive big scanner. The impact on the daily running of the department wouldn't have been that much. Fully roll it out in neuropathology in that we could scan everything that the neuropathologist dealt with. Just how do we take to it? How do we experience the new technology? And so that concluded in January of this year. And now it's in a second phase. Now it's trialing or piloting with other selected specialities within the department, such as breast pathology and gastrointestinal pathology. There are more sort of formal additional audits now being carried out, looking at flow through the laboratory, specific turnaround times, measuring certain performance indicators, which we didn't do formally, but just loosely, but this is more formalized. When we started this, that we would sort of look at the screen and then we would sort of have the slide next to us, and we'd probably spend most of our time in the microscope and then sort of have a dab around this digitized image. But very soon we found it was so easy to navigate through the slide on the screen. There was a sort of a special mouse, so well designed, that I felt far more confident and at ease navigating through the digital image than the slide on the platform. And I mean, I've been doing microscopy for over 20, 30 years, but it only took me 2 or 3 days to almost abandon the one in favor of the other. So they say there were sometimes features that you didn't feel confident about on the screen, and then I would look at the slide as a secondary step. But I never felt compelled to look at the slide first and then at the digital screen, or leave the digital screen out. That was definitely my preferred first port of call, and for most of the cases, the vast majority eventually, I was happy to do all the reporting on the screen without having to look at the slide at all under a microscope. I suppose we had an advantage in digital pathology network, or telepathology network we call it. Between our 3 centers relied on old technology. The Sectra system that we piloted here was light years ahead of that, really easy to work with. The software and everything that Sectra provided was just
interpreting digital images, scanning the slides, and then us accessing the images on our own PCs, and then also exhibiting the images on other, within the same trust, obviously, on the same computer network. I would say a large component of what I've found so enjoyable and good with the system is the confidence it instilled almost straight away. You felt in command of the slide, and in fact I felt more in command of the slide and the pathology on a screen than I was using a standard microscope. It is so well designed and so easy to focus up and down, skirt around the section, look and make sure that you map and look at everything. Far quicker and far more accurate than actually using a microscope. But the idea is to do away with the slides as much as possible. So we would be told that the slides have been scanned, and you would, just like a radiology PACS system, you would just access the slides on your screen, navigate through the slides, and then generate your report. We in the northwest of England, there's 3 neurosciences centres, and we have a sort of a network. Images aren't fully digitized, it's sort of more real-time recording of intraoperative rapid diagnostic smears or preparation. Surgeons operating, specimens sent down to the lab while they're operating. We do a rapid stain on a specimen and then tell them while they're operating what they are dealing with. We can share that information between the 3 centres, Liverpool, Manchester and Preston, and that provides for quite robust cover. So should one of us be detained in court or wherever or on holiday, we can share that via internet links, secure links between the hospitals. And this sort of digitized system share that information or those files on a similar basis. These files are quite massive and big. In-house, it's very easy. Within your own hospital system, just it's on your network, and these massive files are saved on your hospital server.
I think ultimately the best thing is to get some sort of hands-on experience. So I would encourage such departments to, second somebody to at least go and spend a day or two playing with such systems, because I'm sure it'll convert them straight away. Rather optimistic that if you start playing with such a system, people will be persuaded that it's really worthwhile, easy to use, and better to use in many respects.
There's no reason why pathologists can't do some of the reporting at home. So with a better work-life balance, for instance, you could then shift other work that you want to do during normal office hours and do that, and leave a body of work to go and report at home. The logistics of meetings and sharing the information is already a huge advantage. These days, storage space comes at a major premium, so hospital labs they have to maintain these huge archives. Retrieving the slides is an onerous task. They're very heavy, tons and tons of glass slides. If you have everything digitized, that has the potential of avoiding the expense of maintaining archives. It might be that you maintain an archive on the short term, whilst there might be a necessity to go back to a glass slide, but after a few years you might be able to destroy the slides and create new space for the next lot of slides. So from a clinical governance perspective, there's also an advantage in the physical handling of slides, breaking them, losing them, misfiling them, all of that. That sort of problem can be obviated by having a fully digitized system. In our laboratory, and many laboratories like that in the UK, after about 4 or 5 years, the slides aren't destroyed. They're sort of almost maintained indefinitely, but they then go off-site to mass storage facilities, of which there are a few like commercial concerns in the UK. And every time you retrieve the slides from those companies, it costs quite a lot of money, so that impacts on budgets as well. All of this is addressed and taken care of if you have a digitized system, because everything is at your fingertips. The pathologist can do that himself or herself. No need to have dedicated logistics staff or staff to deal with those kinds of logistics. So that has a massive benefit, and now we're not even talking about your sort of reporting, the impact on ease of reporting and confidence of reporting. These are sort of spin-offs from not having to maintain a massive slide archive.
In terms of Turnaround times, which is one way of measuring quality, I mean, that speed of diagnosis, it had an obvious benefit. Can't give you hard data because of this. It was very sort of informal assessment. This is now being more formally done with the second phase of the pilot study. But I'm sure that's going to show that there's going to be improvement on that. You know, what's probably more important is quality of the reporting. I would anticipate, and I'm sure of this, would have systems which facilitate the diagnostic process. So you have pro forma reports that you know, with just a click of a few buttons and stuff, you can have a report out. You don't have to draft or dictate reports, or you just have to tweak it slightly, and that will increase the speed of diagnosis as well. You'd actually have an integrated package for each patient in advance of the MDT meeting, so the radiological imaging and the pathology imaging will already be collated for a patient in advance of the meeting, so everybody can share in that. The fact that you can compare on the same screen old histology and the new histology. So if a patient had an operation before for a tumor and another operation a couple of years later, you can then, you know, instantly compare how the tumors changed or not changed, and you can show and demonstrate that quite quickly. In terms of getting second opinions or getting referring work out for an additional expert opinion, yeah, again, that it's obvious that it will obviate the need to send slides and tissue to other countries or other regions within the same country. You can have 24/7 cover available, a very robust, flexible system. But also, you know, international linkage is something that we hope will come off. Is our hospital's been approached to provide clinical neurosciences training or support for a major region in Saudi Arabia. So we can provide them with cover, we can provide them with an expert opinion, we can provide them with teaching, it can be virtual, real-time. And of course, once other centers internationally, if we need an expert in the United States to give us an opinion, we could link up with them and get the case over quite quickly.
The digital pathology, a digital image on a big nice screen in front of me, maintained my attention far longer. I felt more confident navigating through those images, and the phrase I would use is I felt far more in command of the slide with the digital system than actually with my microscope. I always use a microscope, and there are some things that I will fall back onto a microscope, certain things that might be a little bit more crisper. But nevertheless, as a first port of call, the digital image just instilled a lot of confidence, and I maintained my sort of level of attention far longer. I could rip through more cases before that sort of subjective element or true element of tiredness or whatever crept in, or sort of a lag in attention span. Then there are things like ergonomic advantages as well. At the moment, I've got two screens. One is sort of my reporting system, another one is where my image analysis is done on and my photography is done on, my microscope, and then where my slide trays are kept. I'm forever sort of coasting along on my chair between these. I wear glasses when I read screens. When I look at it through a microscope, I have to take off my glasses. These sort of seem like menial things. There's also hunching over the microscope, which is, you know, lots of pathologists develop neck or back problems. Having just one big screen in front of you, or maybe two screens, but they're next to each other. No slides that you have to pick up all the time, put down. I don't have to take my glasses off and put them on again all the time. It makes a huge difference. It saves time. You know, you're less strain on your neck, on your back, and things like that. It's all at your fingertips. It's all right in front of you. That gives you the sort of confidence of you're more in command of the case.
So if a number of high-profile departments implement it, and then, you know, I think word will spread. It's a fairly small community, but how beneficial the system is, then there will be a, you know, political or peer pressure on other departments to conform. I'm sure this is going to become the norm.
Well, thanks for joining us for the live question and answer portion of the webinar. I'm Mary Tierney, the Chief Content Officer of Radiology Business Journal and TriMed Media Group, and I will be the moderator today. If you would like to ask a question, just please type it into the Ask a Question box on your console and hit Submit. We'll get to as many questions as we can in about the next 15 minutes or so. And on the line with us live today is Dr. Daniel du Plessis, who you just heard from Salford Royal, as well as a gentleman from Sectra who can help out with a little bit more technical digital pathology questions, and that is Simon Hager, who's the product manager within Sectra. So we have a lot of questions, and I'd like to get right into them if we could. And so let's get started. Dr. du Plessis, maybe you could take this first question. I know you're in the second part of the pilot. What kind of performance indicators are you looking at in the ongoing pilot?
Well, I was only involved in the first pilot. The performance indicators are turnaround times, trying to meet certain Royal College of Pathology guidelines for reporting specimens in time, sort of 7-day and 10-day intervals. Those are things that are used in the UK to look at performance with certain targets that have to be met at certain intervals. I think that the second pilot that the general pathologists are busy with at the moment here, well, I will not attempt to actually match those targets, but just will see whether there's any improvement in turnaround time using digital pathology for the first time. Okay. It kind of leads into a question that came in as far as what do you see as there's a lot of benefits to digital pathology as you obviously stated, but what is the primary driver for the ultimate purchasing decision? I mean, it is a little challenging on an ROI perspective depending on what you're looking at, but what do you think the ultimate driver is in having hospitals move to digital pathology? Well, it'll be cost and time. That's the bare bones of it. More rapid turnaround time, greater efficiency or efficient use of the pathologist time. The same applies to laboratory staff who will also benefit from the implementation of such systems. And then there are obvious cost benefits as well, particularly, again, with time saving will lead to cost benefit and then not having to use archive facilities, space, and retrieval of specimens. Quite a bit can be saved on that front as well. Okay. There's also a lot of questions. Maybe you can continue on this as well. As far as the MDT meeting, a lot of interest in that specifically. So how is using the digital pathology facilitating the MDT meetings? What has your experience been as far as sharing patient information with other specialists during those meetings? Oh, well, huge benefit. The first thing is that the routine or the old-fashioned way of doing it is that the slides will have to be retrieved. That will mean that either secretarial or laboratory staff have to be seconded to do that. That is actually quite a demand on their time. They have to go down into the archive to get that. They have to spend quite a lot of time doing that. The pathologists have to wait for that before they can review the cases in advance of the meeting. They then have to lumber the slides over to meeting venues, which might be scattered about the hospital, quite often some distance away. And then the slides, obviously, everything has to be refiled after the meeting. In the meeting itself, showing slides on a routine microscope setup, again, it takes time. These meetings are they're long, lots of cases are being discussed. You sort of lose your audience if you start faffing about trying to find areas of interest. There's a wastage element there as well, and your clinicians might disengage, particularly if they have to look at a lot of cases at the microscopy, whereas if you had all of that digitized, it's immediate, ready access. Pre-MDT preparation time is considerably reduced. The obvious manpower requirements are much, much less. The pathologists can all do this him or herself, in quite timely fashion. And projection of features of interest, you can zoom in straight away on things that are of interest to everybody. You just may want to show 1 or 2 or 3 features, but you can show that immediately. So there's a huge manpower benefits and saving time and maintaining people's attention. In fact, it sort of rekindles people's interest in the histology because it's done in such an efficient and quick way. You can juxtapose previous and current histology on one screen. People immediately can see exactly what you're talking about and how maybe a tumor has changed over time, and that can again be done with just a few clicks, whereas you can't do that with a regular microscope setup. For those people that prepare for meetings, taking advanced photography of the slides, I mean, it's an even greater benefit because that can take a lot of time and preparation. And you have the images at hand. You don't have to do photography because it's already been done for you. And also linking different centers into MDT meetings, that can be done quite easily with such a network, or the sort of network that digital pathology facilitates. You can have second opinions, third opinions, all at the same time. You can marry the images with the radiology as well, and produce all the visuals, radiology and pathology, on the same platform using the same technology. If the service provider is the same, and I suppose different systems can interface. So huge benefits for MDT. I mean, it's one of the, I can say when we started using this just in the pilot fashion, the clinicians took to it straight away, the radiologists took to it straight away. It almost sort of boosted pathology's image. Pathology then became a far more efficient partner in the MDT meeting, whereas in the past, I mean, the radiologists are already ahead of the game. They have PACS systems. They can produce the images. Being able to do the same and actually producing nice color images sort of woke people up literally in the MDT meetings, and it was very well received, even just on the level of sort of a slightly emotional level or appealing to the senses. But the more important thing is the benefits you get from a huge saving in time and a substantial saving in manpower requirements.
Great. Yeah, there's obviously a lot of benefits. I know. So are you sharing information ahead of the meeting or during the meeting, or how does that process work?
Well, at the moment, MDT meetings, most of the information is shared at the meeting, but cases have to be reviewed in advance of the meeting by the pathologist. So having all your pathology digitized makes that so much more an efficient and quick process. As I say, you can bring up images from sort of serial images with time, and patients who have serial biopsies, you can review that all at the same time, sort of real time, and juxtapose these images. You can then also share, I would imagine, we did not do that, but I think that could easily happen. You could share in advance your review with the radiologists as they are busy with their review. So I think that sort of linkage can be set up in advance of the meeting. But in essence, all the information is shared at the meeting, and that's the purpose, obviously, of the meeting. But there is a lot of advanced preparation that can be facilitated with huge benefit by using digital technology rather than routine slide review.
Okay. I mean, I know we're talking about the Sectra digital pathology system. Do you also use a Sectra radiology PACS?
Not at this institution,
okay.
but that is something that's being explored. The region is looking at new service providers. Contracts are up for negotiation, but at the moment, Sectra is not the service provider in Greater Manchester.
Okay, I know. I'm just curious about. Is it essential to have an integration between a Sectra radiology PACS and a Sectra digital pathology PACS? How does that work?
I don't think it's essential. We could easily function without that, and we'll still have most of the benefits. But obviously, I would imagine it would be ideal to have the two systems married. But it's not an essential requirement at all.
Great. Okay. I know you talked about some of the advantages of the collaboration along your region in particular. You talked about workload balancing and expert consultations in general being virtual or real time. Can you talk a little bit about some of the patient care advantages you see moving forward with being able to expand your reach with digital pathology?
Well, I suppose it's been something that's established for some time, but the ideal is that a significant proportion of cases should be double reported. It's a good quality assurance practice. I'm a neuropathologist, and we tend to be small units within much larger general pathology units. So it might be that only one or two people look at a case if you practice in an isolated manner. This allows units to link up, and you will then suddenly get the benefit of forums which can contribute to consensus diagnosis. Many difficult cases can be quickly shared amongst a network that enhances diagnostic accuracy and reliability. That can be done quickly. Obviously, questions can be focused, so it doesn't. That saves time. But in a region, I practice in Greater Manchester, but there are other major neurosurgical centres, Liverpool and Preston nearby. At the moment, although as the crow flies, we are reasonably close together. Such a network can almost effectively establish one unit with the benefit of 6 neuropathologists commenting on a case rather than 1 or 2. And I think that has a huge benefit for patients, in terms of quality assurance, but also robust, more objective reporting, if I can put it that way. Less subject to the vagaries of individual reporting. So that's an immediate advantage. And then, of course, expert outsourcing to other centres as well, internationally or elsewhere in the UK. Again, if most departments are digitized, that sort of crosstalk referrals will be facilitated. I think it will become the norm. And it again means that you don't have to send slides via post, so consultation with experts in the field will be a far quicker exercise, and again that will be to the benefit of the patient as well.
Okay. Let's talk a little bit about your physician training and your experience and things like that. I know you sounded like you were very confident very quickly, but how much training did you get, and how long did it take before you felt you were confident using the system?
The training, I think, I can't give you the exact number of the hours, but it was sort of over a day in total, I would say, exposure to the system. Myself being a bit of a Luddite, most of my needs were on the technology front, how to use the navigational aids and the appropriate commands. And I was surprised how an idiot like myself took to that very quickly, more than usually or normally the situation. In terms of actually starting to use the system almost in a routine manner, I would say that happened within 2 days and I've never used digital pathology before, a platform like this or anything similar. I found it so well designed and easy and approachable, user friendly, that by day 2 I almost abandoned my microscope and stuck to the screen. Obviously one will still use one's microscope where appropriate, but I quickly switched over to the digital platform as my primary mode of diagnosing cases, and then backing that up with a microscope. It was a really quick transition from the one to the other.
Excellent. I think the big topic that almost always comes up with digital pathology is the size of the images. Can you talk a little bit about the large size images and kind of the most efficient and cost-effective way to be able to manage those and that type of thing from your perspective?
Well, I find it sort of describe it perhaps in this way, it is actually less claustrophobic than looking down a microscope. I also felt far more in command of the slide, the surface, felt that I was more confident that I had covered all tissue areas. It was we only restricted the pilot study to routine-sized slides and found that if the specimen surface or diameter was less than 1.5 centimeters for the system that we used, that provide for most efficient use of the system, but larger surface areas was also confidently covered. The quality and resolution was very good to excellent. I can't give you exact screen surface sizes, but we could cope with almost anything within a normal slide dimensions. It was just a very easy system to use to navigate through the sections, and in fact, the speed with which one covered the the surface, I found was better than navigating through a microscope. We sometimes feel you might be missing something, and you have to adjust your objectives all the time to make sure that you are covering all bits of tissue. Whereas with the screen, that was an almost instantaneous process with the way which the handheld sort of device allowed one to navigate through the field.
Okay. Simon, maybe could you talk a little bit about the size of the digital pathology image? Just kind of, I know that's a big concern in people's minds, and also talk about, are they managed as DICOM or TIFF?
The sizes of the pathology images, they are really large, and when the Sectra packs receive them, they are already compressed, so they are about 0.5 gig to 1 gig size. And what we use is kind of a streaming technology, so we only fetch the really necessary information, like 1% of the total data that is necessary for the pathologist to actually review the case. And regarding the DICOM, it's really coming, and we see that more and more scanner vendors are adopting the DICOM standard, which is very good from a user standpoint, since the users can use whatever scanners they want for specific purposes.
Okay, that makes sense. Now, what has been your experience as far as how the digital slides are stored? Are they stored with radiology images, or are they on a separate server?
Both, I would say. So it's basically up to each hospital according to their image storage strategy. So some will store them in a separate pathology system. Some will utilize the benefits of economics of scale and store them in the radiology and other imaging systems, like the vendor-neutral archive, for example. So both, I would say.
Okay. And then one more technical question, and then I'd like to go back to Dr. Duplessis with a final question. But is there a recommendation on the resolution for the monitor when you are looking at slides, or the bigger the screen is, the better? And what about luminance as well? So let's talk a little bit about the displays and what's optimum.
Okay, I realized the previous question. Sorry, is that for Simon?
Yes, maybe Simon could answer that first, and then I'll go back to you if that's okay.
Sorry, no problem.
I can just start, and Dr. Duplessis can explain his experience, maybe. And what we see is that the resolution is very up to the pathologist, what they feel comfortable with. That's the most important, I would say. So what we recommend is just the 30-inch monitor and 4 megapixels. And maybe you can fill in, Daniel.
I got a very fancy monitor and stuff, so I suppose I've got a state-of-the-art thing, so I can't tell you what I'm willing to reduce that to, but working off standard screens, actually most of the time fulfilled my needs. If the question is in part one at which resolution or at what magnification it should be scanned at. I think all ours were scanned at times 20. One would always be selfish and want something more, so we did look at times 40, and of course that had some benefits, but the size of the files then becomes quite big, and we quickly adjusted to times 20, but then using digitally focusing on top of that. I mean, there are sometimes things that you might miss or where it's not optimal if it's not scanned at times 40, but we found times 20 to be satisfactory for most cases.
Great. I'm just going to ask Dr. Duplessis one more question because I know we're getting a little bit short on time. We have a lot of questions that have come in, and we will try to email some answers out to some of these questions as well, just as follow-ups. But maybe, Dr. Duplessis, just as kind of an all-encompassing, feedback question, I guess. You talked a lot about the improved confidence with digital pathology, but what do you see this meaning for the practice of digital pathology going forward?
Our basic skills will remain the same, but I think it will become it will just become far more efficient. There are pressing needs on our time, pressing need on skilled staff, and this will have the benefit of far better networking. It will bring us probably one big advantage. It will to some extent bring us out of our dark rooms or back rooms and allow. It's almost like, I suppose, the internet where people with specific interests and skills were quite isolated in the past. This will make for a much happier family, people who can approach each other much more quickly, allow for far greater crosstalk rather than individual isolated practice, and that will only benefit, will be much to the benefit of patients. So I think it'll be more of a sort of an open commune, if I can put it that way, rather than this isolationist practice that many of us have practiced or have been employed in the past. I think that's the main. I mean, the basic skills will remain the same. The science will remain the same, but it will be far more robust and benefit from, difficult cases will benefit from multiple opinions at the click of a button.
Excellent. Yeah, there's huge value to that collaboration, so that's great. I want to thank everyone for joining us today, and a special thank you for Dr. Duplessis and to Simon for your great answers. I know I learned a lot today, so it was excellent. And if anyone missed any part of this webinar or would like to listen to it again, or would like to forward it along to a colleague, you will be emailed the link over the next couple of days to the on-demand event that can be shared. So thanks and have a great day.